thoracostomy. The indications for this procedure are threefold. The first is a traumatic cardiac arrest with chest involvement. The second is positive pressure ventilation with signs of barotrauma. And the third is a suspected tension pneumothorax with signs of respiratory or cardiovascular compromise. The signs we look for include tachypnea, dyspnea, anxiety, tracheal deviation, hyporesonance on the affected side during percussion, diminished breath sounds on the affected side during auscultation, cyanosis, jugular vein distension. Note that this may not be present in patients that are hypotensive. The contraindications for this procedure are two. The first is cardiac arrests that have been going for greater than 20 minutes with no signs of vital signs. And the second is an obvious non-survival traumatic injury during the traumatic cardiac arrest. Complications of finger thoracostomy. There are a number of complications that can occur with this procedure. We can create a simple or tension pneumothorax. We can create a hemothorax, hemorrhage, lung laceration, air embolism. This is all due to improper diagnosis and improper insertion techniques. Improper insertion can also include massive infections. We can perforate into the abdominal cavity. We can cause life-threatening injury to the heart, greater vessels, and lung damage. This is why it is crucially important to pay careful attention to the anatomical landmarks that we are going to use, and why we use sterile techniques as sterile as possible to reduce that risk of infection. Make sure after this procedure that you are frequently checking for signs of redevelopment of the tensioning pneumothorax, and also note that there is the risk of that thoracostomy becoming occluded when we package that patient's arm. The risk of exposure to blood and body secretions is high in this procedure, so make sure that goggles are worn. So why would you perform a finger thoracostomy over a needle decompression? While needle decompression is quick and there is few materials required, it should be regarded as a temporary measure. Firstly, due to the insufficient length of the needle decompression cannula, in the majority of patients it is unable to reach into the pleural cavity. Secondly, when there is no rush of air heard upon insertion, it can be impossible to determine if there was a tension pneumothorax present, if the cannula has become kinked or occluded, or it is in the inappropriate place. With finger thoracostomy, all of these complications are avoided. It also allows for maximum release of air, and it also allows for maximum re-expansion of the lung. The equipment required for this procedure includes a sharps container, gloves and goggles, an occlusive dressing, gauze to wipe out blood and secretions, a skin preparation solution such as chlorhexidine, forceps, and a safety scalpel. The procedure for the finger thoracostomy is a number of steps that involve infection control and appropriate placement of the required items. So firstly, we would take appropriate infection control measures, such as donning gloves and goggles. Secondly, we want to abdicate an arm greater than 90 degrees to expose the area that we want. Next, we need to identify our landmarks. So the first one we do is the lateral border of the pectoris major muscle. What we are looking for here is the triangle of safety. Our second anatomical landmark is the anterior border of the latissimus dorsi. Third, we want the base of the axilla. And finally, we want the fifth intercostal space in line with the inferior nipple in males and the mammillary fold in females. This gives us our area. Next, we use our skin prep. In this case, I'll just use a gauze swab, and clean the area in a back and forth motion. We allow this to dry naturally. Next, with our safety scalpel, we would make a 4 to 5 centimetre incision in the fourth intercostal space, just into the subcutaneous fat. We would then dispose of this in the sharps container. Our non-dominant hand would hold the forceps and push just into the pleural space past the intercostal muscles and make a wide enough incision that we can create a tract for finger insertion. We would then remove the forceps once the finger is inserted, and we would do a 360 sweep to make sure that we can palpate the parietal pleura and to make sure that any air has escaped and that there is re-expansion of the lung. After this, we would place an occlusive dressing, seal on 3 sides to prevent re-expansion or redevelopment of the tension pneumothorax. After this, we monitor for signs that the tension pneumothorax has been released. There would be a decrease in tachypnea, dyspnea would improve, subcutaneous emphysema would lessen, the patient would increase cardiac output and blood pressure, and any other signs that indicated a tension pneumothorax would start to decrease.